Hello, hello. Thank you so much for joining us. We are thrilled to have you here. So, you are joining three groups that are coming together to facilitate this event. This was started by Medicine Forward. It was sponsored by KNN, Kern National Network for Flourishing in Medicine, such a long name, Jeff Fritz. And then, of course, Healthcare Reinvention Collaborative. This event is a second event to one that we together hosted in New York City on November 20th. And so this is going to kind of be piggybacking off of the conversation that started there, because what we really believe is discussion is great, coming together, sharing ideas, making connections. That's wonderful. However, we need action. And so this event is going to help us to move forward towards action. The purpose of this event, so as I said, it's that follow up to New York City at the Burnout Symposium. We focused on a question of how do we restore and nurture the human connection so needed in healthcare together today. I looked here saying together, but the word was today. We are at that event, we used open space technology. Dawn's going to give us a little bit of an orientation to that because we'll use a bit of that today in this event as well. We ended up with nine different topics that those who joined us discussed. We're bringing those nine topics here again today, and we will have you help us identify if those nine topics are the ones that we continue the discussion today with. The second opportunity or reason for this gathering is to foster collaboration and connection. So we, in an hour and a half, we're not going to be able to do the types of connection that we really like to do, unfortunately. But what I really encourage you to do is use the chat. Drop your name, your location, any information you'd like to share about who you are, what you do, where you are. Drop your LinkedIn URLs and make new connections. And then follow up after the event, especially if you shared a breakout room with somebody and you want to get to know them further. Please make sure that you do so. That is one of the primary rationales or reasons for an event such as this, is to make new connection. We are not about talking at you. We are talking with you and developing relationships. So I acknowledge and say sorry about the lack of ability to give you time to truly have introductions during this and during your breakouts. Those breakouts are also going to be time sensitive. But again, make connections using the chat. Dawn, anything else in intro that I should say before we get going and toss it over your way?
I think that covers it. I'm going to work on sharing what I want to share here. So if you want to catch anybody else straggling in,
Yes, I've got the
there
waiting
comes
room.
Lisa. All right. So the question that's bringing us together today is, how do we restore and nurture the human connection so needed in healthcare today? And as Denise mentioned, we started this conversation on November 20th in New York City. And let me just, my movement is, there we go. So again, we're using a little bit of open space. The four principles are: whoever comes are the right people, whenever it starts is the right time, whatever happens is the only thing that could have, and when it's over, it's over. Those are what I call the hippy dippy principles of open space. And the law of mobility is really important and different from what you're used to. So, if at any time you're feeling like you're not able to contribute or you're not able to learn, then you are encouraged, if not expected, to move to another space. So, with this virtual venue, you can just ask to leave the room and you'll go back to where Denise will be, and she'll help you get into another space. So, the law of mobility and the four principles are this passion and responsibility kind of yin yang interface that makes this such a wonderful way to have conversations. So, I borrow from World Cafe for the open space etiquette. So, I want to encourage you to focus on what matters, contribute your thinking and experience over your conclusions. Listen to understand, connect ideas, listen for patterns, insights, and deeper questions. We're going to set the agenda by having a poll today. We'll show you what topics came up in New York City on November 20th, and ask that you look at those carefully. We'll have the descriptions for you dropped in the chat, and you'll be able to choose which conversations you'd like to be in. Then you're going to hold those conversations, capture your learning. The hosts in your room will have a worksheet where they're trying to capture the insights, and then there'll be an opportunity we're going to have two different sessions, as Denise mentioned. After the first session, we'll report out the highlights very briefly, tweets rather than encyclopedias. Within the conversations, the hosts are going to encourage all of you to participate. They're going to be paying attention to the clock so that 5 minutes before the time to close, we're going to make sure we're capturing all those ideas in that worksheet. And if you wish to continue the conversation, there will be some opportunities to continue the conversations. So again, there will be these worksheets where they'll capture the topic, the host, the participants, the key insights, ideas for action, and really important, who else needs to be invited to this conversation? Who isn't here that needs to be here? The influencers, the stakeholders. And we want to try to make sure that next time we get together to talk about these things, they will be included. Again, for the reporting of the highlights, we want a tweet, not an encyclopedia. We'd rather the host not be the one to report out because we want you all to be engaged in that kind of leadership. And so if you'll step forward and say, yep, I can be succinct and tweet out the highlights, we'd really appreciate that. So again, our umbrella question is, how do we restore and nurture the human connection so needed in healthcare today?
All right, so we have 9 rooms. I'm going to let this slide sit here for a moment and you can think through. We did provide these in the documentation via email in advance to this event. So hopefully you had a chance to look over the different topics and get the brief summary that was also offered. What we're going to do, we're wanting to make sure that the breakout rooms we create have people within them. So if one of the rooms nobody votes for a topic, then we'll just close that room. So in just a moment, I'm going to launch a poll where you're going to let us know which of these topics most align with your interest. But Dawn, did we want to ask if there was any need for
Clarification?
Yeah.
Sure. Is there anybody that needs some clarification on these topics? We're happy to clarify the topics if needed. You see any hands, Denise? I don't see any
I'm
hands.
not seeing any hands.
Anything in the chat?
I see, yes, medical marriage. Eva, I wonder if you could help define that one. Tell a little bit about that one.
Sure. So anyone who is a health professional or is married to a health professional or health professionals married to health professionals, contributing to the conversation of how that dynamic influences care. Yeah, I would say in all realms of that word. So the dynamic, it's a focus. Dynamic, yeah.
Thank you. And somebody else asked about WB. Thank you so much for that. That's well-being. Yes, Lisa, thanks for that confirmation. So yes, we're going to have 2 breakouts. The first breakout, the focus is going to be on the question, what could we do? So that's just really ideating around the possibility. Nothing is too far-fetched, really being able to brainstorm openly. And in the last 5 minutes of that breakout, you'll narrow that down to what are those biggest, brightest, boldest ideas that you came up with, and you'll share those as we come out of the one breakout room. And then when you go to the second breakout room, now we're focusing same topics, but now it's what should we do? So from what was ideated, and maybe something else pops up, but what should we do? And you've got another 20 minutes with 15 minutes of really good discussion and sharing, and then 5 minutes of what are you going to share succinctly when we come back together?
And someone asked about wellness curriculum. Yes, I believe that discussion is about providers. So wellness curriculum for providers.
I was trying to see if I had that
real
quick.
And yes, Lisa, participants can switch groups. Yep, that's the law of mobility.
So I'm dropping the wellness curriculum into the chat. All right, ready for the poll? We have only 1 person in managing medical marriages, but I think the other groups have a strong enough poll that those look good. We do have quite a few people in patient empathy and clinician well-being. So I am going to remove managing medical marriages, and that leaves us with 8 polls or 8 breakout rooms. Eva, you'll move to the one that I was going to be in, which is helpful. You are in navigating competing agendas. Okay, so now you voted. You do not have to go to exactly the one you voted for. You gave us an idea of what we needed for breakout rooms. So let me delete this one. And we've got 8 rooms. Any questions before we pop into breakout rooms? Brian, I see that. Okay, Brian, if you can't contribute, you can still listen. If you're able to put into the chat, feel free to contribute that way as well. All right, I'm going to open the rooms. If you're having, what's the process if you want to leave a room? You'll see in the room, you should have a option to leave the room. So when that comes up, make sure you don't hit leave the meeting, or if you do, just come on back into the meeting, but leave the room. I'll be in the main lobby, so I'll help you find a new room to get into. Excellent. Here we go. I'm opening the rooms.
Yeah, so while we saw the notes, is there anything else that we'd like to just get more specific on when it comes to what we're envisioning for this reconnection of values and mission?
A structure that gives the providers, the healthcare providers and nurses time, and that honors that sacred relationship that we're trying to preserve. Health was never supposed to be individual billable transactions.
Mm-hmm.
You know, I just went into a school. I'm a substitute school nurse, and there's a big sign on the wall, and it says, remember, the biggest predictor of any child's success in this school is the relationship with the teacher. Same thing is true of health.
Mm-hmm.
The greatest predictor of someone healing is the relationship they have with the nurse and the physician, whether they trust or believe, whether they have hope or apathy.
What are some approaches that you've seen work, Kathleen?
Work to do what?
To facilitate those relationships.
The Band-Aids that I've seen that work, rounding, bedside report, those are Band-Aids.
Mm-hmm.
They're all Band-Aids. They're all Band-Aids that improve the process. Shared governance, those are all things that everybody's focused on improving the process, when in fact, we need the cell phone.
So we have 3 more minutes, just an FYI.
Thanks, Denise.
Wonder where Karen went.
Oh, she's here.
Sorry, I'm here.
Oh, okay.
I was just going to touch on something that I know is not well received as far as popular opinion, but the truth is, I think we also have to look at, we talked about in our group, the different people coming into the system. The system has been hijacked, if you will, to become a business. And we have a population of people who have entered into this industry, and I'll use that word, industry, looking for making a good living, work-life balance, which quite honestly is a very United States mindset. That is not a global mindset, this work-life balance per se. But we have people coming in that are no longer, as we talked about, looking at this as a calling, it's a business. And I think we have to look at what is the quality of the output that our academic systems are delivering to the system. We are tailoring the educational process to be quicker, faster, leaner. Oftentimes that's at the peril of even that mental, emotional preparation for connection in your practice, whatever level that practice is. If it's all about task, how to do a skill, how to pass it off, like I go into hospital after hospital and it's people sitting at a desk on their phones, socializing, like even when they have the time, they're not choosing to use that time at the bedside or in a connection with a patient. They're choosing to do it outside on their own. You have to shift the entire psychological structure of the people in the system.
You can't shift it. You can't shift it. You have to create a new structure that by its very nature invalidates their psychology, I think. I don't think that shift's possible.
And may not be. Not wrong.
All right, the rooms are closing. So some people will hang out those final seconds. We've got a few that are here with us now. That time always goes by way too fast. All right. I think we're back. I'm looking in the sea of faces and looking for Dawn. There she is.
I'm here. Okay, and I'm going to ask for report outs from the different groups. And who would like to report out first? And I apologize if I don't see your hand, just speak up.
Well, I can go first from our group if you would like. We talked
Thanks,
about,
Mindy.
you're welcome, the patient-clinician communication. And we had quite a discussion about like how we could get there and how we could improve it. But basically it came down to that there be allowed significant time and training for practitioners to utilize evidence-based tools to improve their communication effectiveness so that they could build trust, connection, and help the patient to feel safe, and that would be helpful for both the patient and the clinician. That would help both of them. So when we talked about evidence-based tools and how we would get there.
Great. Thanks, Mindy. Who's next?
I can go. For our group, we were understanding leadership, and we talked about potentially using some decolonizing methodologies, maybe some world cafes or group relations conferences. Someone shared the term that I like. They're a conscious capitalist of healthcare, but how we really need to look at it, how we establish trust again within healthcare. That there's a lot of power dynamics, and we need to look at our relational and empathetic relationships. I think coffee chats was brought up as a way, just as a simple way to have conversation and how to have difficult conversations, some physician suicide rates, but most importantly, how we use the data that we have, whether it's financial programming or quality improvement, employee improvement data. And I think that was it, and how we also can just shift the mindset. If I'm missing something, can you add on from my team?
All good.
All right, super. Next group, who's up?
I'll share for the group talking about wellness and empathy. We talked about how empathy can be increased in both directions, and one of the main strategies would be to taking more of a narrative approach where both clinicians maybe were taught in training to gather points of detail about their patients, even just one or two that humanize them, and similarly that the patients perhaps could be given a few humanizing details about the doctor they're about to see, maybe about interests or family dynamic or something, family structure. One shared the question that they sometimes ask of patients, can you share something that has given you joy lately? And we did talk about how time is often the limiting factor, that the narrative piece takes time. And so part of the solution is figuring out how to decompress the encounter and structuring it in a more effective way, like opening the first few minutes for more of a dialogue rather than always steering the interaction. So basically we emphasized training of medical students and residents to include more humanistic details in the intake, and somehow working to improve the time.
Thank you, Mary. Who's next?
I can go for the technology group. So we came up with many more questions than we did solutions, because I think this is such a huge topic. But so one of our group members is doing work on leveraging digital tools to think about how it improves relationships, which is our topic, and brought up that we need to think about relationships not just with healthcare workers and patients, but also with our peers, and even relationships with family and the impacts technology has on that. And a conversation about understanding and increasing skills, both from the clinician side and the patient side, and the concept of digital literacy and how to increase digital literacy. One thing that came up was telemedicine, and how that's been really a technology that's taken off, and are there ways to consider how you might use telemedicine to improve people's well-being even outside of clinical encounters, which I thought was a provocative question. Another thing that came up is how to integrate empathy into our digital tools. And so again, lots and lots of big questions. A few more things that came up. So there's so many tools that we have, and so it can be quite overwhelming switching between them, and that takes away from some of our time to be human. And that there's this big issue of that tools not sharing with each other, and that really we'd like to see a world where patients could own and control their data. And so again, a huge question that we don't have answers to, but do think it's important to have these conversations. And the information needs to be more mobile and not locked into proprietary silos. And so a couple ideas. One was increasing the mental health awareness of our technology. So what if the EHR could understand the amount of strain that it was putting on a person who was using it, and even integrate with other platforms that might be doing things to improve well-being, like something like Headspace. And then really thinking about, can we get people to shift mindsets from sort of protecting their own business and data to incentivizing more collaboration and less zero-sum game thinking with technology, more sharing and more openness. So I think that's a good place to stop.
Great. Thank you, Gabe. All right. Who's got the next tweet out for their group?
I can go.
Go ahead. Thank you.
Thank you. So we were talking about peer community support. It was a great conversation. And so one of the key items was we are human beings. We need community. We need belonging for survival. And connection has been shown to increase outcomes and profits. And so it's not just a woo-woo concept. It has business acumen as well. And it allows us to see the other person's pain point so we can support each other more deeply. We had a great conversation about the healthcare community as far as the practitioners and the neurodiversity and the diversity. And as it becomes more and more transactional, it's starting to squeeze out actually that great, beautiful diversity component. And then as healthcare becomes more transactional, it's diminished the meaningful impact for both the clinicians and the patients. So that's contributing to people leaving and the burnout and all of the other things. So we had a business and a nursing and a physician and a pharmacy perspective. It was a great conversation.
Thanks, Michelle. And who will go next?
I can jump in for the financial austerity group.
Thanks, Jeff.
So we spent a lot of time working through what I would call the challenges of siloing and how things and efforts seem to be siloed. And while there's a lot of energy, it seems to be dissipated or disconnected. For example, who makes the decisions from a healthcare insurance agency to fund and move in a particular direction may actually be disconnected from what happens at the provision of care level. And how do we work across those siloed spaces, even in spaces of where we think through how does nursing policy influence other areas of the healthcare policy, ranging from budgets to outcomes. A lot of our energy began to focus on really what healthcare needs to be as we think about the reflection of it meeting the needs of all the people in this country, rather than those that might be making the decisions or developing the systems of that. We did have some really interesting ideas for action that started from big to small. And the smallest one was, as we move into spaces to meet with others, to ask the simple question to ask somewhere in that meeting is, how will today's discussion or today's energies influence the ability for us to restore and nurture care?
Mm-hmm. Thanks, Jeff. Who's next?
I'll jump in next if I can, because we'll parlay off of Jeff. We talked about the competing agenda group, and initially we had to kind of hone into what exactly that meant. Is it competing agendas as clinical practitioners dealing with the concept of a work-life balance of how do we serve our patients, serve our families, what is our each individual competing agenda versus looking at the competing agenda of the healthcare system as a whole. You have competing agendas differing where the clinicians and the bedside hands-on people perceive things to be one way, but you have the competing agenda of assuring that you're meeting the financial or fiscal responsibilities of the system and the insurances and all of those other components of what makes up healthcare today. So we talked a little bit about the focus being on the structure that's in place to yield a process to get an outcome. And do we have a unified vision of what that structure, process, and outcome is and should be? Is it about the outcome of good, healthy patients and the quality of care, or is it about the fiscal benefit of being in healthcare or the ability for healthcare to continue to deliver? We talked about what came to mind for me was Bucky Fowler's statement that you just can't fix the existing structure. You have to break it down and build a whole new one. And that's kind of where we ended up was we're probably not going to be able to keep the system. We're going to have to maybe reinvent the whole thing. So what's the vision? What's the dream? What's the mission? What are the values within healthcare to yield a unified outcome? And then how do we create the structure and implement the processes to get us there? And then we talked about the disconnect between people on one side of the industry versus the other. Again, going back to clinical people have a focus on X, whereas maybe leadership and management has a focus on Y. And even if they have the same ultimate goal, we're not talking to each other in the same language so that we're yielding a process to get the right outcome. So we've talked really about how do we get back to the basics of identifying the mission and the value of what healthcare is and should be, and then how do we steer that to yield the outcome that we're all hopeful. And I think everybody in this call, we're preaching to the choir because we're all here for the same concept. But that's really what we honed in on.
All right. Any groups that have not presented other than my own? Other groups? Leah, Bruce, or Pontia, any of you want to report out for us, or shall I take a stab at it? All right, so I'll say that I'll take that as a no or yes or whatever that is. So we talked about how sometimes we're talking about wellness curriculum, and sometimes the wellness curriculum is very prescriptive. This is what you need to do. This is one more thing that you need to do. And could we roll that back a bit and really partner with our providers and be with them and handhold and, more on the lines of workshops and retreats, creating that space for them to talk with others about what they're struggling with. One of the things that we've noticed providers are resistant to is that word resilience. And how can we define that differently so that they can recognize that they may be very resilient if resilience is defined as resisting adversity. But how good are they at recovering after a trauma, or how good are they at rising above a trauma? These are different skill sets. And yeah, we talked about the difference also of empathy versus compassion, and how if we can practice compassion in our clinical settings, that lifts us up, it lifts the patient up. It's the empathy of feeling the pain that lights up our pain center versus the compassion, which lights up our pleasure center, according to the functional MRI study. So those were kind of the top ones that we discussed. Did we miss anybody?
I think we got it, Dawn, but I was not
All
good
right.
about tracking everything.
I was trying, but I
There's
lost
so
track.
much, so much. So good. And here's what we're doing next. You get to go back into breakout rooms. So I'm going to put up the same list of breakout rooms. If you have challenges, just let me know what room you want to go into. Not everybody at once, one at a time, and I'll get you there. No worries. But we're going to get you into those breakout rooms again. This first one was what could you do? Now you're focusing on what should you do. Facilitators, I dropped the link to your worksheet. It's just for the facilitators. Don't forget, if you haven't closed out the prior workshop, to do so we capture all that great information. And I'm going to open up those breakout rooms. You have 20 minutes. All right, look at all the faces returning. Yay. Dawn.
So who will report out for, let's go backwards, wellness curriculum. Bruce, would you report out for us, please?
Which Bruce? Me?
Bruce Trimbley, sorry.
Oh, okay. I didn't realize there was even two Bruces here.
I didn't realize you were in our group, so.
I wasn't, that's why I got confused.
I'm teasing you. Bruce Trimble.
Yes, so one of the things we talked about in terms of what we should do is providing more education, some things similar to this, providing retreats as well, but making those retreats kind of a la carte. So kind of like we have here, we've had multiple topics to choose from, and we weren't pre-assigned, and we could go from one group to another. So we like that flexibility. Also making it multidisciplinary, not just focused on the physicians and the medical staff, but also on incorporating the entire ecosystem. And then in addition to making it kind of a la carte, providing some micro learning as well. Kind of like we have here, we're not reporting out in an encyclopedia format, but more like tweets. And then finally, one of the things that was suggested was providing, just as we have our annual physicals, mine's coming up soon, incorporating a mental physical as well. And so making that part of the preventative care for our staff to prevent burnout and enhance resiliency.
Thank you. All right, next group. Who will step forward?
The other Bruce will go.
All right.
Excellent.
Ours is we're not communicating between healthcare professionals and patients. So our shoulds were we should revisit healthcare professional training to include evidence-based communication training in the same way that we talk about evidence-based medicine. We must work with accrediting bodies as kind of leverage in order to get this into the curriculum, because evidence seems to be that the schools don't necessarily do this on their own. There's also, we talked about that there's opportunities in the curricula to reduce other areas in the curricula. One of the areas that some of us talked about that's overblown is basic science. So to reduce some of the basic science to make room for this, and to also have champions that are within healthcare we need them at the table, because a physician may be more likely to listen to a Jonathan Fisher, for example, another physician who's doing these things in order to make these kinds of dreams come true.
Thank you, Bruce. And Dawn needed to step away, so I'll ask for our next contributor.
I'm happy to go next. Or we got a whole bunch of volunteers.
Oh, nice. Lee.
Sorry, Jeff. Yeah, so I'm just reporting back on the technology group. I'm sure, like everybody, was a fabulous discussion that we could have gone on with probably for the rest of the evening, to be honest. But yeah, really, really good discussion. I think one of the main things that we were talking about was trying to unlock the potential for the use of technology within the healthcare environment as a passover from the commercial landscape, because what we can see in the commercial world, where we have profit-driven environments, technology is leaping forwards at a fair rate of knots in many areas that would be super useful for healthcare, whether that's better data insights that can empower healthcare professionals to communicate differently with their patients, depending on where their patients are located and what they're suffering from, and their different cultural or deprivation indices. Or whether it's, Jennifer spoke about process improvements and operational efficiencies. So when we're thinking about trying to free some time up, because in my previous group, we were talking about the power of time. If we're trying to free time up as a commodity, are there ways that some of these commercial technologies can be used to improve operational efficiencies or process efficiencies that could be cashed back in for more patient time? What would that look like? We also spoke about if we're going to make a genuine sort of leap into change and change management, what would it look like for this group to think about maybe a few really small micro examples of bringing together maybe some technologies alongside some more sort of patient-based experts, and think about some micro examples of change that as a group we could sponsor or be associated with, so that we have some use cases with some outputs around some things that we all passionately believed were better ways forward that could be used to influence systemic change further up the system. And then we spoke about the power of bringing in voices from other parts of the world where the healthcare systems are very different, and whether or not in those healthcare systems they've got challenges that they can share, or even things that have worked better that they can share that may or may not be useful for the unique environment in the US.
Excellent. Thank you. And who would like to volunteer next?
I can go next.
Excellent, Mindy.
I was with the Empathy Wellbeing group this time.
Thank you.
I think that was the right title, something like that.
Yep.
And we started the conversation with talking about how time was so important, and that it was critical that we help administration see the impact, both for physicians or clinicians. I don't want to say physicians, clinicians and patients, for time, that there be adequate time, and kind of struggled with who helps us with that. Is it unionizing or using ANA, AMA, something along those lines to help us with that? And then we moved into recognizing providers who go above and beyond. And lastly, a great discussion on how important biography next to biology is. And is there a way to place that in the EMR so that other people would be able to see who that patient is, as well as what's going on with them? And because we didn't get to re-practice this before I left the group, let me know if I left anything out.
I'll just add what Lee said, that I was hoping that maybe this organization or some organization would embrace some micro practices that we could advocate for, because I don't know, clinicians are hesitant to do things that are not traditional. And Mindy was talking about it. She and I used to put all of our personal stuff in sticky notes. Why is that not important to put in the chart, the biography next to the biology? Because that's how we actually make better care and better connections with our patients. So
thank you for that. So my tracking says we have 3 more groups: the role of peer community, understanding leadership ecosystem, and how do we do this in the era of financial austerity. Who's next?
I can go for the understanding leadership ecosystem. So one thing that we talked about was coaching, and I'm a huge advocate for coaching and helping, whether it's leadership or, physicians, whoever, to help them to find their purpose, so that it's, whatever they're working on is more sustainable. We talked about in the current system, and the coaching is important in this, is finding a way to, survive, the current system, and for it to be viable while you're, looking or other opportunities to improve the system, or work at the problem in a different way and find solutions. We talked about shared leadership models. And obviously, when you're working on those solutions, what do the solutions look like? I think we all agreed that this is probably going to be a grassroots type solution, which is what HRC is all about. So, 100% agree about that. We talked about large organizations, and we talked about Dunbar's number, which is really important to me. And if people don't know, it's the suggested cognitive limit to the number of people with whom one can maintain stable social relationships, and the number is 150. And so if you don't think that large organizations are socially responsible to their employees and who they're serving, I think that, inherently they're exceeding the limit. And then we talked about our all, mutual love for the Buckminster Fuller quote about making systems obsolete. And then we also discussed, my, personal thoughts, which is, some on the call are aware of my, venture studio concept for physicians to be entrepreneurs and owners of their own businesses, and, not limited to physicians, but healthcare, people in healthcare in general. I mean, I think that the only way to have sustainable, effective change in leadership is through better ownership. So
thanks, Dan.
I think that covered. But if anybody else in the group wants to add, please do.
And two more groups.
I'll jump in with the financial austerity group.
Thanks, Jeff.
A lot of our discussion centered on things that have already been mentioned here today, but probably our key takeaway was, one, being grateful that we are having the discussion and noticing that this discussion happens at a timely point in time, and that it also was something that might have not easily taken place just a few short years ago, but that there's the need and that we should look for ways to continue this discussion in proactive and active fashions throughout the upcoming year. Other things that we focused on, I could have just basically said ditto to what Bruce Trimble started with in terms of education, the need to change the story and to have a holistic story that involves patients and all members of the care team.
Thank you, Jeff. And by my account, we have one left, the role of peer community.
We had a pretty heated discussion, which is why I think nobody is raising their hand. It was a great conversation, and I think that we challenged each other, which is part of why we're here, and it's not just nobody's here just so we could talk about what a great job the system is doing. So let's have some of the tougher conversations. And we got to, I think if we were going to summarize it in less than 1 minute, I would say the idea is, along with the Buckminster Fuller quote, show something that works and creates obsolescence of the current system. What would that look like? It would look like basically a population health model, where in a grassroots level, in a small setting, you would do something akin to an ACO. Some people like the idea of using the terminology ACO, some don't, but that's okay. We can all agree we're talking about a population health model where you take a certain number of people, and instead of billing on a fee-for-service system, you bill to keep those people well, which means that you're going to start focusing on the basics: clean air, clean water, healthy food, transportation, childcare, education, and only about 40 cents on each dollar would actually be on healthcare, which would be provided in the community very close to where people are living their lives. And I think that we can all get on board with that. Then the pushback comes, yes, but there are powerful people profiting from the current status quo, and it will be difficult to scale that. We're not going to cure that problem today, but together, I hope that we will.
Thank you, Marianne. So trying to put a workshop of this nature into 90 minutes is a challenge, and we did it. We squeezed it in. We kind of wedged it in there. This discussion is just the tip of the iceberg, and moving it to action will take more gatherings of this nature. So I hope that you will join us as we suss out some of those what should we do's, and we step into that further. Now, how do we go about that, and who's interested in test of change and playing a little bit? Thank you for joining us today. We'll stay on if you want to stay with us. I'm going to do some closeout. I understand if your calendar needs you to go. So please, we won't be sad if we see, well, we'll be sad if we see you go, but we'll understand seeing your face go. The next steps, what we do want to let you know is we will be capturing all of this insight. So your facilitators took notes as fast as they could to get it into worksheets. So we've collected that. So there is more than what you could share with us in the short 10 minutes between sessions. We will consolidate all of that information. We will share that on the platform. So you will have access. Most of you, I'm looking at faces here. Most of you are already on the platform. So you will see that there. You'll see the summaries. You'll see the what next there. And are you interested in taking this one that seemed to have a lot of activity to a further conversation that moves to action? We are all about action. Dawn, do you want to say anything in closing?
Just thank you, everybody, for showing up. It just shows how dedicated you are to the cause. And we just really appreciate your contributions and what we're learning from you. And we look forward to seeing you again. And I am one of those people that has to jump off because I have a call coming in. But thanks again.
Thanks, Dawn. Gabe and Jeff, if you want to say anything, I'll give you a moment as well. But also, we are at the top.
Oh, no, just thank you. And I guess the one thing that came out of our last group that I think is worth sharing is that people are already experiencing individual value from being part of HRC in an economic way. And I thought that was actually really interesting that like people have found each other and are working on projects. So this like coming together. Yeah. So I think that's just a super cool thing. And I hope that we can make more of that visible because I think that's what's going to build momentum is like realizing that like it's not a total black box that, you know, like things are happening.
Excellent. Thank you for sharing that. Jeff, anything final from KNN you'd like to contribute?
I just wanted to extend my gratitude for us thinking through how we can move into this space for both all of us across the network, because being a patient is the most inclusive club you'll be in, and to look for ways in which we can promote each other's flourishing. Wishing you a wonderful day.
Thank you, Jeff. All right. I will watch faces go. If anybody wants to stay and chat, and I'm here. Otherwise, have a fantastic day and happy holidays.
Thanks, everyone.
Thank you.
Thank you.
So Denise, what's the appropriate way? Is there anything we as a group facilitator? So of course I kept everyone's names and some of them were interested in continuing the discussion. Even possibly somebody brought up making a video or something.
Awesome.
So I was just wondering, like, should I, you know, get the emails of the people in my group and just reach out to that? Like, was there going to be like a system of for us, you know, those who wanted to continue this, like a next step?
Yeah, really good question, Kim. So here's the nice thing is people registered. So I have their emails and many of them are on HRC. And so we'll be sharing out there. They can connect out there. They can exchange other information there. But yes, if you want to submit the worksheet to make sure that we have that information.
I did.
Fantastic.
I hope you got it. I did.
I'm sure I haven't looked yet, but I want to be able to say, okay, here was the discussion and who was in that discussion. Because part of that's going to be on that map that we're developing, but it's also going to be recognized in the platform. Yeah, excellent, Kim.
And I just think I'll add is we are doing it, right? These conversations are actually doing it. And it's specifically ours, you know, patient empathy, clinician well-being. We had a couple patients that have been harmed by the healthcare system. And then we had doctors who have also been harmed by the healthcare system. And just being able to listen and hear each other's perspectives. And that's what we talked about, or that we want to figure out is how can we do this between individual doctors and patients, but between groups of doctors and patients, or, you know, on a larger scale. So just having this conversation today, right, is doing it.
Indeed.
One thing that came up in our group that I think was interesting was the idea of looking to other models that have kind of spread collaborative ideas. So like something like Wikipedia or GitHub for open source technology, like open sourcing these like ideas, like micro things that are working, but like how to organize and open source those things so someone can find them and contribute to them and build off of them. I think was like one of the things I left feeling inspired to think more about.
Indeed, Gabe, exactly what we're thinking about. Creative Commons, those types of things. We want to lean into that.
So Denise, I can't help but notice that when I was part of the PX initiative and also HRC now, there are some people missing in the rooms, and they are, for patient experience wise, our chief experience officers. People in the highest positions in our healthcare systems do not have the time to come or do not, I don't want to say care, but how do we get those people in our rooms? And as I continue to interview for these positions, whether I want these jobs or not, they keep coming my way. And I have had the sheer, I would say, I mean, I've been fun employed for 1.5 years and I get to be part of these conversations, but what about those people? What are they doing to contribute? And so I worry about that.
Yeah.
That is such a great point because those are the decision makers many of the times. And yeah, wow. Yeah.
Mm-hmm. And that's a fine balance because one of the things that we find, I mean, we've been trying to shift the efforts, the mindset of those in the senior suites or the high level positions for decades, and we haven't gotten anywhere. So it's kind of this groundswell that we're looking at. But you're right, we cannot just groundswell. We've got to somehow meet and integrate in the middle. And so I love that question, that identification, and I don't have a solution. So Tricia, Allison, others, I am open for the ideation around that.
Well, one interesting thing that I would share. So one connection I made from last year's Burnout Symposium was this woman that works at Stryker, and they created this initiative for people who are like executives of big healthcare systems to commit to some of these like human principles. And there's actually a list of some pretty high level people that drafted. I'll share a link as soon as I'm done.
Thank you.
I find it. But I actually wonder if like reaching out to some of the people that are already on that, like they made this charter basically that say they care about these things, and to invite some of them to a conversation that we maybe kind of spend some time thinking about how to bring them into something like HRC.
Well, Gabe, you and I were on a conversation this morning where I kind of pushed back a little bit about people with power, with the work they do, the knowledge they have, having more weight for the decision making. And that's one of the things that concerns me as well, because just because somebody's in a certain position and or well known does not mean that they have the answer. And so I really like those who are at the ground level being able to have an equal voice in what we're doing.
Yep.
Kathleen.
I couldn't help but notice when I looked at all the breakout rooms in the beginning that the premise was the current system. And when I think of the two loops model, I know that there are people improving the current system, but I don't see anybody creating that totally new system. I don't see anybody working to stand up a new system that makes the old one obsolete. And that's what I'm interested in. That's what I was hoping to find in this group.
Yeah. And you're right. That is our premise. Thanks, Kathleen. I think that's really important.
Yes, it was a little, even after the first, readout, it was like, everybody's talking about the same system.
Right.
Like, oh, I thought we were supposed to do the two loops.
Yep. I love that.
Kathleen, I'd love to. I don't see your last name, but if you are on the
Bartholomew.
Okay.
Yeah.
If
Has
you
a
are
great TED Talk.
If you are on the HRC platform,
She
I
is.
invite you to connect with me because I'm trying to do something kind of avant-garde within the space of leadership, not just in healthcare, but how to infuse fun, which is wellness, into conferences where individuals are sent by their organizations to the tune of $9,000 to $10,000 to an individual conference where they're supposed to come back and make transformational change, and they don't. They
can't because it's the same system.
Right. But also nobody's working on healing the individual. So I would like to offer space within a conference where an individual works on the home within themselves so that they can then take the information from the valuable conference and then change transformational, sustainable change to the organizations to which they serve.
I think what you're saying is they will change themselves.
Yes, they will, but they have to be guided and coached on how to do that. Sometimes
I think the two of you are going to have a great conversation. I look forward to hearing more about it. Robert, I see your hands up.
Yes, thank you, Denise. So I guess kind of riffing off a little bit of what Tricia was saying about not having the right people at the table. All of these things that we're talking about, patient experience and the experience of our clinicians and so forth. And that my work is very like financially focused and looking at resource allocation. Do we have the right amount of resources to do what we want to do? And the things that we're talking about, like wellness and compassion and empathy. When you get down and you look at care delivery, what it really boils down to is time. We have to have the time to do those things. And if you look at it, and expand it out a little further. When you're talking about burnout, well, it's time. We have to have the resources available to give people the time off to rest and recharge. Right. We also have, because of the nature of healthcare, that educational component is very important too, especially when you look at what's happened since the pandemic, where at least on the nursing side, the average tenure of the nurses has decreased, right? And because of the baby boomers retiring between now and 2030, we're going to be losing something like 2 million years of experience each and every year with these baby boomers retiring. And so we have to provide the space, the time, and the resources for people to be able to take the mental bandwidth or the mental time to do these things, to process these things. Because when you're working and you're so short staffed, one of the first, and you've got so much that you've got to do before you leave your shift. Very often, because of that stress, one of the first things that's going to go is the compassion and empathy, because you've got to get everything checked off your list, and you may not have that 10 minutes to stop and really have that conversation with that patient or that family member. So for people that are missing at the table, on my end of the nursing world, we really need the human resources people there, and we need the finance people there, because the implications of time really comes down to bodies and money. And so how do we ensure that we have the money to recruit and hire the bodies we need to do the things that we need to do? And I'm not just talking about patient care. Through my work in the mathematical modeling around nurse staffing, I can go in and I can show you that, because we know that if you want to schedule staff for a given, basically nursing is looking at delivering a desired level of patient care for an expected volume of patients. And we know how much that takes. And if you hire that much, that's great. But what happens when somebody goes on vacation? What happens when somebody calls out sick? What happens when somebody needs to go to an education day? We have to have those additional resources to step in and maintain that level of patient care. So the industry is so focused on productivity and care delivery that we've really sort of lost sight of. It's actually the non-patient care stuff that allows us to provide that safe and effective patient care. We have to have more resources than we need for patient care, so we can provide employees with time off so they can rest and recharge. Then we need more resources beyond what we need for patient care and time off, so that we can do education and orientation to maintain and improve the competency of our workforce, which is extremely important for positive patient outcomes and patient safety. So that's kind of my long-winded way of saying, we do need some of these decision makers at the table. And, if we are talking about things like, compassion and empathy and wellness, we also need the people that hold the purse strings, because ultimately it boils down to time and money.
Yeah.
Robert, love the passion for the work that you do. Thank you so much. Gabe, I see your hands up.
Yeah, no, I just so Robert gets me all fired up with what he's talking about, because I mean I agree with everything that you said, but I actually think that time is further down the list than mindset of this system. And so in particular, for anybody who hasn't heard me talk about Orchid Health, I want to talk about it for one reason, and that's that they work within the existing kind of payment scheme of U.S. healthcare, but have decided that well-being of the worker is the most important business priority. And so they measure and operationalize that. And so new patient visits are an hour long. A clinician sees 11 patients in a day. They have blocked out time for culture work in the organization, and for people to do projects a little bit like Google that does their kind of work on what you think is important. I don't know how I made these balloons. Make them when I want to. But so the whole point is to me, and I'm a huge fan of Donella Meadows' work in systems thinking and leverage points, that the mindset and the paradigm is actually more important than something like how much time or how much you pay for something. And so and I think this has actually been hypothesized by lots of folks, that if we get people to commit to that well-being of people is the paramount, most important thing, and then you're going to do these other things, everything else starts to shift. So I actually would argue that just expanding time and saying we need more time without fixing that higher level leverage point of getting people to change their thinking about that the goal of the system is, Jeff, human flourishing or well-being, all the rest of this stuff doesn't work. So that's my goal, is to get more people thinking about a well-being first operating system for whether it's the existing healthcare system, and we're going to move towards that, or these new models, these upstarts that are trying to build something different, and from the foundation building with that, the top level leverage is the mindset is sure, it's a business, but why is the business here? It's here to provide care to people, but also we need to create great jobs where people can show up and be their whole selves and not be run into the ground.
I love that. Gabe, I'm just going to say a short comment, and then Pantia, your hand was up next. One of the shifts, Gabe, is individual shift too, because I know when I worked within healthcare, there's this little source of pride, or I'm better than, among nurses saying, I haven't gone to the bathroom in 12 hours, or right. I mean, we've got to get over that as well. I worked for a company student group where the CEO would scoff at anybody who needed more than 5 hours of sleep at night. We've got to shift that type of mentality in order to lean into what you were mentioning. Pantia, your hand was up.
Yeah, so I just want to, in the nursing world, we say piggyback on what everyone else said. When I use all caps and, like I put in the chat, it's not an angry and, it's a Boolean and, because I don't know, teenagers use caps to yell at you, but this is just emphasis. So everything everyone said, and like Gabe was saying, time, I get it. I've been a bedside nurse. And that's the first justification for not creating change is lack of time. But mindset and equipping people with practical tools to use in the moment, so that if I'm a nurse and I'm in the room and I'm spending, I don't know, 10 minutes with the patient anyways, doing a head to toe assessment, charting, I have to be in the room, whether it's 7 minutes for the physician or 15 minutes for the nurse, we're in the room, right? So how can we stack empathy and compassion on top of the time that we're already in there? How can we make eye contact? How can we be more present? How can we use the time we're charting to also engage with the patient? So yes, we need system-based changes. Yes, we need systematic culture change so that leadership supports compassion and empathy, but there's also things individuals can do. So again, going back to, and it's equipping individuals with the coping tools so that they can operate and give compassion and empathy under highly acute distress situation in healthcare, and fix the policies and procedures that are in place that are an impediment and a barrier to people who want to give compassion and empathy. So it's a both and.
Pontia,
Yep.
I mention you often with you give some really good examples, but you're right. It's not, I'm not going to do anything until they change the system. It's no, there's stuff that we can still do. We may not be able to change the big picture, but the little micros that we can do can be a wave, can be a ripple of change. Trisha,
Yeah,
I
and
see-
at the end of the day, the organization is made up of individuals, right? So
Indeed.
yes, we need to change policies and procedures and practices and all that, but we also need to equip individuals to change.
Indeed. Trisha.
So I can only speak of this individual because that's what I've been trained in my life experience. And for me, as a leader in healthcare who did have the power as a acting chief experience officer with the title of assistant vice president, patient experience, I felt that what I needed to do to contribute to this change was to be vulnerable and to say to my team of 100, which I've now learned is within that, what did we learn
Dunbar's
today?
model. Yep.
Dunbar's model. So I had a team of 100, and it was the height of the pandemic where I'm leading the C-suite into the emergency rooms, into the COVID units, and I'm rounding with them, with patients and families. And I'm saying, there's some scary stuff going on in the world right now. I just recently lost my cousin because she thought she could fly and her body did not catch up with her spirit. There, I worked with Dr. Lorna Breen for 6 years in the Allen Hospital of New York Presbyterian, who, after trying to fight hundreds of people in a 16-bed emergency room, could not and chose suicide. And I needed to tell people that I, as their leader, am not perfect. No human being is. So I decided to share openly about my diagnosis of mental wellness and how I have made decisions consecutively in order to be able to lead the team. And did the organization love it? I know that they did not. The organization was like, you could not, as our leader, speak with Panta at a conference with the name of our organization. You must remove it. And that's sad. So when we're talking about, leadership and vulnerability and making the change, that's all part of it. And just being who I am, it did take, as you mentioned, for me to go to the people who were holding the budget behind my budget to say, I will support you to make change across the organization. But if I didn't have my 10 years foundation in public relations and marketing and convincing and a master's in negotiation and change, I don't know if a leader could have actually gotten to make the change in the 3 years that I did. So it's about leaders that are willing to take the risk. And I don't have that job today, and I'm perfectly fine with it. If the organization does not want me in that role or does, serve me, I think it's an important thing to realize and to move on. Like you have done many times, Denise, you've role modeled that. Where can I best serve? So I think that it's important.
Thank you. I always love the after event conversations. They're so rich. So I'm grateful that you were able to share. I can stay for a few more minutes if you wish, or whatever works best for you.
I just want to thank you, Denise. Like the work you do inspires me, it's a thankless job. You're doing it on your own time. You've been doing it for so many years. We're programmed to operate on reward, whether that's monetary reward or whether that's admiration or respect or accolades. And you get very few of them, if any, and you keep going. Your passion is so strong. You've built a community. You've gathered all the like-minded people. I mean, I admire you all the time. The world needs you, and we're all behind you. So I just wanted to extend my gratitude and wish everyone blessings for a blessed holiday season. May we have more unity in the world, more peace around the world, between nations, between different people, and unite people in compassion. Wishing everyone a blessed holiday.
Oh,
Thank you,
that's
Pantia.
awesome, Pantia.
Thank
That's
you.
Warm winter wishes to everybody.
You too. You too.
Beautifully said, Pantia. Thank you.
Thank you.
Denise
All
and
right.
Kate and everybody.
Yeah.
Okay.
Take
All right,
care.
Take care. Bye.
Appreciate you all. Bye-bye.